Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show. Methotrexate, it is a category X drug. It is an antimetabolite acting against folic acid. If both methotrexate and folic acid are there inside our body, methotrexate is structurally similar to folic acid and has high affinity to dihydrofolate reductase. So this enzyme dihydrofolate reductase still chooses this methotrexate to bind, even it has its natural substrate folic acid inside the body. By inhibiting this dihydrofolate reductase enzyme, folic acid won't get converted to tetrahydrofolate and further DNA synthesis will be inhibited in immune cells, which leads to immunosuppressive action at low dosages, that is less than 25 mg per week. At higher dosages, it will act as a cytotoxic useful in hematological cancers. Anti-inflammatory action is by inhibiting ICAR transformylase enzyme, aminoimidazole carboxamide ribose 5-phosphate, ultimately leading to intracellular accumulation of adenosine, which leads to reduction in inflammation. Antifibrotic action via reducing collagen by inhibiting collagen production and increasing the degradation of collagen by matrix metalloproteinases. Coming to pharmacology, it is available in oral tablets, IV, IM, subcutaneous and topical formulations. Reaches peak within 1 hour with 50% of plasma protein bound, T-half of 4 to 5 hours. Metabolized in liver to form methotrexate polyglutamate. Both this metabolite and the drug itself are active. Excreted mainly via kidneys, 95% unchanged. Coming to FDA approved uses are only two. One is psoriasis, another is Sézary syndrome. Rest of all are off-label uses: immunobullous, autoimmune connective tissue, neutrophilic and proliferative dermatosis like pityriasis rubra pilaris, pityriasis lichenoides et varioliformis acuta, refractory cases of alopecia areata, atopic dermatitis, keloid and keratoacanthomas. Coming to side effects, mainly myelosuppression, most common cause of death. Nausea and most common GI side effect is vomiting, abdominal pain. Chronic diarrhea indicates toxicity. Folic acid supplementation of 5 mg per day except on methotrexate day will prevent this GI side effects. Hepatotoxicity in the form of liver fibrosis, lung fibrosis may also occur very rarely. This fibrosis is due to toxic effect on the liver via its metabolites and leading to injury, inflammation and finally fibrosis because of chronic usage of drug where cumulative dosages reaches very high like 3 to 4 grams. Renal dysfunction in case of drug overdose. This drug will precipitate in renal tubules and causes renal dysfunction. We have to treat by hydration and alkalinization of urine. Coming to idiosyncratic and life-threatening side effect, acute pneumonitis. Idiosyncratic means dose independent. It may occur even with a single dose. Skin and mucosal adverse effects like hyperpigmentation, cutaneous recall reaction like phototoxic recall, radiation recall, oral stomatitis, ulcers and rapid ulceration of psoriatic plaque indicates toxicity. Clinically, how we can guess toxicity is rapid ulceration of psoriatic plaque and chronic diarrhea. Via lab testing, if total leukocyte count is less than 3.5k, platelet less than 1 lakh, creatinine more than 1.5 and twofold increase in liver enzymes indicates toxicity. How do you treat this toxicity? By supplementing tetrahydrofolate, as this methotrexate is blocking the conversion of folic acid to tetrahydrofolate. If we give directly tetrahydrofolate, this DNA synthesis will continue in the form of folinic acid, leucovorin calcium, citrovorum factor, not folic acid. We are giving tetrahydrofolic acid, that is folinic acid. It is inhibiting production of blood cells. We can stimulate by giving granulocyte monocyte colony stimulating factor, filgrastim. If creatinine clearance is less than 20, we have to stop the drug. If it is in between 20 to 50, we have to reduce the dosage to half. This is based on renal function tests. This is liver function test. This is CBC. All this we have to do before giving drug. And then we have to give a test dose of 2.5 to 5 mg. Then after 1 week, we have to redo the test. If normal, we will proceed to the actual dosage of 5 to 15 mg per week. And we have to also check pregnancy, HIV, TB, hepatitis B, hepatitis C, all this, because of chances of reactivation of TB. As a lung rule, remember this, whenever you are giving a immunosuppressive drug, we have to check for TB, like chest x-ray to rule out latent TB, and we also have to check for HIV. These are all relative contraindications. Renal and hepatic dysfunction, alcoholic, diabetic and obese, these are all relative contraindications. Pregnancy, lactation, significant leukopenia, anemia, thrombocytopenia is absolute contraindication. Coming to drug interactions, probenecid, phenytoin, phenothiazine, triple P elevates methotrexate levels. CAP, ciprofloxacin, amiodarone, penicillin decreases methotrexate levels. What are the drugs contraindicated along with methotrexate? Whatever the drug which also inhibits folic acid metabolism, we have to prevent. Why? It will also lead to myelosuppression, leading to significant pancytopenia. Examples are dapsone, sulfonamide, cotrimoxazole. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. Das vidania.